Dear colleagues, a warm welcome to this webinar of the ESCO, the ESTRO, and the ESP. It is our pleasure to introduce to you the new triple European guidelines in endometrial cancer. We've set up this webinar series, 4 webinars prior to the summer break, to inform you on all the important changes and topics in these new triple European guidelines. Today we will focus on surgery. And together with my co-chairs, Remy Newt and Xavier Mathias-Gouilly, I will guide you through these webinars, and I kindly ask my colleagues to introduce themselves.
Hello, good afternoon. My name is Remy Newt, radiation oncologist from Rotterdam Erasmus MC in the Netherlands.
Hi, my name is Xavier Mathias-Gouilly. I'm a pathologist from Spain, and it's a pleasure to chair this session together with my colleagues Remy and Nicole.
My name is Nicole Konzin. I'm gynae oncologist from Austria, and we have a fantastic faculty with us here today. Thanks a lot for taking the time. Anna Fagotti, president of the ESCO from Gemelli Clinic in Rome. David Cibula from Charles University in Prague, past ESCO president, and Christina Fotopoulou from the Imperial College of London, world renewed for debulking surgery. Very happy to have you with us. Thanks for joining us. This is the agenda of today. We will at first focus on early stage endometrial cancer and particularly on lymph node staging. And thereafter we will discuss, so please send your questions in the Q&A section. And then we will continue with advanced staged and relapsed endometrial cancer. And again, we have a lot of time for discussion planned in after the talk. The next webinar will take place on 22nd of May. This will be dedicated to adjuvant treatment. And then we have the 4th and last webinar on 24th of June. And this will be dedicated to metastatic and recurrent endometrial cancer. So please save the date and join us at these webinars. I encourage you to send your questions so we can have a lively discussion after the talks. Send your questions anytime during the talks, via this Q&A section. And of course, you can also chat with all the colleagues that are present via the chat function, but we prefer that you really send us your questions and that we discuss them together. And now it's my pleasure to give the floor to Anna Fagotti. Thanks you, Anna, very much.
Yes, give me 1 second. I will make my camera working. Okay, so good afternoon, everyone. Thanks to the co-chairs for this nice introduction. And I will share with you some information coming from the new updated guidelines in endometrial cancer. These are my conflict of interest. And let's start with a pre- and intraoperative workup of patients with endometrial cancer. Some of these are already known, so we will repeat some of the information that you have. Preoperative mandatory workup includes family history and general assessment of comorbidities, geriatric assessment when appropriate, clinical examination, pelvic examination, and expert transvaginal or transrectal ultrasound or pelvic MRI. So assessment of the pelvic status of the patient. Whereas depending on clinical and pathological risk, additional imaging modalities like CT scan, MRI, or PET scan can be considered to assess ovarian ovarian, nodal, peritoneal, or other sites of metastatic disease. So in other words, if we want to make a scheme, we can say that we can use for local staging either only ultrasound or MRI, pelvic MRI, to consider the size of disease, myometrial invasion, cervical invasion, and parametrial extension, not vaginal extension, because this can be done with clinical examination only. Whereas with CT scan, PET-CT scan, or whole abdominal MRI, we can assess nodal spread, peritoneal dissemination, or distant metastasis. Why should we consider extrauterine disease? For special histotype, aggressive tumors, or special molecular status. Indeed, also, histopathological tumor type and grade in endometrial biopsy is required. And if we look at the literature, and we have data starting from 2016 up to yesterday, 2024, we know that the grade and histotype have either substantial or moderate agreement with respect to final histology on the surgical specimen, as you can see here, whereas we have an excellent agreement if we consider the molecular status assessed on preoperative endometrial biopsy. Therefore, our guidelines suggest that molecular status should be considered and achieved through the endometrial biopsy before surgery. Regarding surgical approach, actually nothing has changed over the last years, and we have this study, which is the LACE study, multinational phase 3 randomized trial published in 2017. This included only presumed stage 1 endometrial cancer, any grade, only endometrioid. You see here patients were randomized 1-to-1 between total abdominal hysterectomy or laparoscopic hysterectomy. Interesting here, there was a quality assurance for the surgeons involved, who were 27. Almost 750 patients were enrolled, and the primary outcome was disease-free survival. You see here the results. So there was a very low number of events in both arms, and there was no difference in terms of recurrence rate. The probability of disease-free survival at a median follow-up of 4.5 years was equal in the two arms, as you can see here, and the same was for overall survival. So the conclusion is that here you see the description of the type of recurrence based on the different approach, abdominal or laparoscopic, and you see that there is no difference for any of the sites of recurrence. And the conclusion is that although there are some limitations, but some of them actually are cannot be avoided in any way, like the blinding of patients and surgeon, of course, was not possible, and the randomization was before surgery scheduling. However, MIS is equal to laparotomy in stage 1 endometrial cancer in terms of disease-free and overall survival. In terms of quality of life, it's very difficult to analyze each of these boxes, but anyway, I can tell you that the red one is abdominal hysterectomy and the blue one is laparoscopic hysterectomy, and quality of life was measured at different times, like baseline, 1 and 4 weeks, 3 and 6 months. And of course, there is an improvement over the time. And at any time, in most of the cases, especially if you look at the functional variables, you will see that laparoscopy is favored compared to abdominal surgery. This is even an older study, so I just want to show you the main results and tell you that we have 2 randomized trials that supported actually the role of minimal invasive surgery in endometrial cancer patients. These were actually a more advanced or a more aggressive disease, because they include also uterine carcinoma and sarcomas, stage from 1 to 2A. So you see again any histology and grade. Randomization was 2-to-1. The groups were very well balanced. You see here the risk of recurrence in the 2 groups, and there was no difference. Again. The recurrence-free survival was, as you see, very similar at 3 years. And here again, you have a description of the recurrences in the two arms, and there was no difference. There was a low rate of port-site recurrences, as you can see, but most of these patients had actually metastatic disease at time of diagnosis. So 3 or 4 had already metastatic disease. Also, one of the main discussion or limitations of this study was the high rate of recurrence, which of conversion from laparoscopy to laparotomy, which was about 25%. So 1 of 4 was converted to laparotomy for many reasons. The most frequent was actually the poor visibility, the BMI, and bleeding or cancer present at time of diffuse cancer at time of laparoscopy. So this was the main limitation of this study. And regarding the poor visibility, there was no quality insurance about the surgeons, but all these patients actually were included only if they could achieve complete pelvic and para-aortic lymphadenectomy. So of course, in very obese patients, this could be a problem, especially in those times when laparoscopy was performed. Okay, I just already said this. And we have also many other studies, mainly retrospective studies, confirming that laparoscopy or minimal invasive surgery in general is a safe approach also for patients with high-risk endometrial carcinoma. And by the way, we have now very recently published a very large meta-analysis, which was on around 2,300 patients, many studies and many patients with high risk where there was no difference in terms of disease-free and overall survival in patients who underwent minimal invasive surgery. Regarding uterine manipulator, I don't know how many of you use the uterine manipulator. There are many studies in the literature, but with different results. So I just mentioned some of them. I want to mention this because this is of course retrospective, and this is a meta-analysis of 18 studies for more than 6,500 patients. And you see that actually this study shows that there is no difference in terms of LVSI incidence between uterine manipulator and without uterine manipulator, recurrence rate, positive peritoneal cytology. This was actually a positive study, we can say, because the uterine manipulator does not increase the rate of recurrence and lymphovascular space involvement. We performed a prospective study on the use of uterine manipulator, randomizing patients into 2 groups with and without uterine manipulator. The main objective of this study again was the presence of substantial lymphovascular space involvement. There was some differences in terms of operation time, and we actually considered this as related to the timing for setting up the uterine manipulator, which is very complicated, at least the one that we used. And the final results at the end showed that these are the 2 arms which were comparable, of course. And the final result was that there was similar pathologic findings in terms especially of the primary outcome, but also regarding other histological findings in terms of positive lymph nodes. There was also a similar rate of malignant peritoneal cytology. However, and this was, although it was not one of the main objectives, of course, with a very short median follow-up, there was no difference in terms of progression-free and overall survival. There is, however, another study. There is, however, another study which was again conducted on a very large population of 2,600 patients. Again, retrospective and multi-center. I think it comes from Spain, where at the end the results are conflicting because here we see that there is a higher risk of recurrence in patients receiving manipulation of the uterus if they have an endometrial cancer. And the authors suggest different reasons for this finding, which is mainly the spread of the tumor through the myometrial wall or even through the tubes, as you can see here in point D. And indeed, the rate of recurrence was much higher in the group with uterine manipulator with respect without uterine manipulator, and of course, the disease-free survival was lower with the uterine manipulator. So these authors, of course, discourage the use of uterine manipulator for patients with endometrial cancer. So just something about the uterine manipulator, we still have a randomized trial ongoing in Italy, which is called MANEC, because at the end of the story, we don't have, let's say, definitive conclusion about the use of uterine manipulator in patients with endometrial cancer. Regarding the type of MIS, all the studies have been conducted, including laparoscopy only. And today we have robotics. So is there any difference in this regard? This is a study, this is a French study, which is a randomized trial for patients having all gynecological tumors, not only endometrial, but also cervical and ovarian cancer, which was conducted to show whether there is a higher risk for severe perioperative morbidity in patients receiving robotic surgery with respect to laparoscopy. And they found that there was a very, there was no difference actually. And there was no difference also in terms of disease-free and overall survival between the two different approaches. However, as you know, robotics is considered the best approach for patients with high BMI, as the ones that we have with endometrial cancer, and therefore we are now conducting a prospective randomized trial in obese patients only with endometrial cancer with a BMI higher than 30 between laparoscopy versus robotic to show whether there is any difference in terms of performance of minimal invasive surgery. And indeed, as you can see, the primary endpoint is simply conversion rate to laparotomy. You see here the inclusion criteria, and this is a multicentric trial, so anyone who is interested can join. And right now, 100 patients have been enrolled, and the overall number of patients to be enrolled is 566. So, in conclusion, stage 1 and 2 endometrial carcinoma, what we suggest that hysterectomy plus bilateral salpingo-forectomy is the preferred, the standard surgical approach, together with sentinel lymph nodes that David Sibula will speak about, plus infracolic total or partial omentectomy in serous carcinoma, carcinosarcoma, and undifferentiated carcinoma. MIS is the preferred surgical approach, including patients with high-risk endometrial cancer. Any intraperitoneal tumor spillage, including tumor rupture or morcellation, including in a bag, should be avoided. Intraoperative frozen section of the uterus is not encouraged for a myometrial assessment because of poor reproducibility. For stage 2, more extensive procedures should only be performed if required to achieve free surgical margins, and this includes vaginal cuff and parametrial resection. If vaginal extraction risks uterine ruptures, other measures should be taken, for example, mini laparotomy, and this is the case where it's not considered a conversion and is still minimal invasive surgery. A pre or intraoperative finding of metastatic spread outside the uterus, excluding lymph nodal metastasis, is a relative contraindication for minimal invasive surgery. I think my time is almost concluded, but I just want to tell you something about the type of hysterectomy, because these are also very old studies which are still valid today. And this is a randomized Italian study between class 1 and class 2 radical hysterectomy according to the Piver classification, the oldest time. But this was a very interesting study on more than 500 patients that shows that there is no difference in terms of either progression-free or disease-free survival, and overall survival. And for stage 2, we have this very large meta-analysis on 10 studies on almost 3,000 patients, again, where they show that there is no difference in terms of radical and between radical hysterectomy and simple hysterectomy. And this is why our guidelines suggest simple hysterectomy only. For stage 1 and stage 2 is endometrial cancer. Ovarian preservation. I think this is also very important. As you know, we have published some guidelines regarding the uterine preservation in the past. So we will discuss in these guidelines only ovarian preservation. You see here the cutoff value, and you see also that we don't suggest ovarian preservation in patients at hereditary risk for ovarian cancer, such as carriers of germline BRCA mutation or Lynch syndromes. But for the others, we consider ovarian preservation for patients included in the new staging system FIGO 2023, stage 1A1 or 1A2, with low risk of recurrence by molecular classification. Who are these patients? These are patients who have molecular subtypes polymutated, MMRD, or NSMP, low-grade ER positive. For all the others, unfortunately, we still don't have data in these regards. And I'd like to show you some data about the ovarian preservation and the risk of ovarian metastases according to the different molecular status. And you see that we have 0 cases among 14 polymutated. We have 2% with copy number low, whereas we have up to 45 and 50% in the other molecular families, let's say. So I think these are very interesting data that can be confirmed, but very reassuring for some molecular subtypes. And more or less the same about uterine preservation. This is not the case. We did not touch this point, so we will not discuss this, but you can find information within our other guidelines about uterine preservation. So I still have 3 minutes. So about incomplete primary surgery, we can say that if there is no residual tumor, should be, of course, these patients should be always referred to specialized centers. And restaging surgery should be avoided in patients with low-risk disease as defined by uterine pathological and molecular factors where available. If we need to remove the remaining cervix, adnexa, omentectomy, and sentinel nodes, and this should be considered in non-low-risk patients if the outcome might have an implication for adjuvant treatment strategy and after careful assessment of the morbidity of the procedure. And of course, after staging with imaging. Just to let you know, and this is something that probably David will touch later, if we have the cervix and we are planning to remove for any case, just remember that first you can perform sentinel assessment, sentinel lymph nodal assessment through injection of ICG through the cervix. Still 2 minutes. So for the surgical unfit patients, I think I will leave the words to our radiation therapists. Of course, we can consider always the vaginal approach, vaginal hysterectomy and bilateral salpingo-forectomy, or if surgery is still contraindicated, even if with a very, very minimal invasive approach, then we can consider radiotherapy or systemic therapy like endocrine therapy or combination of different local treatments. I think this is the last point, but what I would like to discuss and open this with you is about the follow-up. I think this is very close to the patients, first of all, and we had a representative of patients in our guidelines. So this is very sensitive for both clinicians and patients. So, and these patients should be informed and counseled about their follow-up. What we have discussed during these guidelines is that patients should be counseled about any other potential disease that they could develop in the future just because they had endometrial cancer. So these are usually obese patients, these are old patients, these may have diabetes or hypertension. So what we should do is not only a follow-up related to endometrial cancer, but consider the patient as an entire as a woman. And so according to all the other disease that she can develop in the future, they should be informed about signs and symptoms and side effects and psychological assistance. I think this study was very interesting about the real impact that follow-up and multiple intensive clinical visit or even imaging that we can offer will not change the outcome at the end related to the endometrial cancer. As you can see here, I don't want to take too much of your time, but you can see the reference here. Whereas the results is that at the end, overall survival is very similar between interventional and minimal follow-up regimen for these patients, and doesn't change even in high-risk patients, whereas the cost related to this approach are very different. So I think it's very important to discuss with the patients. Quality of life doesn't change. And this is my last slide. I don't want to take much more time, and thank you for your attention.
Anna, thank you very much for this fantastic talk. We will discuss your talk together with David's talk. And I encourage everybody, now it's the chance to submit questions to Professor Fagotti. Please send your questions. We will target them afterwards. And now it's my pleasure to have David Zibula with us, and he will target with us the lymph node staging in endometrial cancer. Thank you, David.
Thank you, Nicole, and I'd like to thank ESCO for inviting me and for having me here. I have to admit that this chapter was developed together with Ignaz Vergotte, and he did a great job in this aspect. So on his behalf as well, I'm very proud to present this chapter. Those are my disclosures, and well, from one aspect, my talk can be just 1 minute, because on the algorithm it covers just this one line. So it says that in all stages, early stages, stage 1, stage 2 endometrial cancer, concerning lymph node staging, there can be one approach, and this is sentinel lymph node biopsy. In the footnote, it says that if SLN is not detected, then site-specific systematic lymphadenectomy should be performed in high-risk patients. So in high, intermediate, high-risk patients, and can be considered in intermediate risk patients, of course, based on prognostic factors which are known before the surgery. So we can stop here because it covers all. But in recommendations, there is a little more information. It says that SLN should be, and there is a change. There is a move towards SLN biopsy from the previous version, when we still considered systematic lymphadenectomy as an option. Here we say that SLN biopsy should be performed for staging purposes in all patients with uterus confined disease. We also say that ICG is the preferred detection technique. It also says that all SLNs should be sent for pathological ultra staging. I am very grateful to pathologists that they agreed on at least some recommendation for the pathological ultra staging protocol, because this is something what we really need such international consensus. So it says that at least 2 levels of ultra staging should be done. In line with FIGO staging, macro and micro metastases are considered positive lymph nodes, and the prognostic value of ITC is still a question mark. So that's it. What is in the guidelines. I'd like to give you a little bit more background, as Anna did previously, starting with the history. Those who are younger, they may not remember, but in this field, in lymph node staging in endometrial cancer, we have quite some evidence already, and it's older evidence. And there are two prospective randomized trials on lymphadenectomy versus no lymph node staging. So at that time, the aim was to evaluate whether lymphadenectomy has any curative potential. The first study was from Italy. The quality of surgery was pretty good, at least if we consider the number of lymph nodes as one of the parameters. And you see that median number of lymph nodes was 31 from pelvic lymphadenectomy, medium number to one patient, and there was no survival benefit from lymphadenectomy. And there was another study, Aztec trial, another prospective randomized trial. So again, patients were randomized to lymph node assessment composed of excellent biopsy plus systemic lymphadenectomy versus no lymph node staging with the same results. So we have actually two level A evidences showing that lymphadenectomy in early stage endometrial cancer has no survival benefit. But then later came SLN era, and SLN era again opens the door for lymph node staging with the purpose to tailor adjuvant treatment. So we do it not for curative principles, but for staging purposes. And here I'd like just to show you the main trials. One of them was a prospective SENTI-ENDO trial. And all these patients received excellent biopsy followed by lymphadenectomy. And what authors showed that SLN had a very good sensitivity, meaning that there was, in this study, there was just one patient who had a negative sentinel lymph node, but positive any of other pelvic lymph nodes. So the sensitivity of excellent biopsy for pelvic lymph node status is excellent. Another prospective study, FIRES trial, this time almost 400 patients. All of them received SLN followed by full pelvic lymphadenectomy. Again, excellent sensitivity. So only one false negative case, false negative SLN. Importantly, this study from Memorial, it was retrospective analysis, but in this retrospective study analysis for the first time, they showed that also patients with early stage, with low risk tumors, meaning a grade 1 or 2 and less than 50% of myometrial invasions, even these patients may have positive lymph nodes, although the frequency was much lower. Still, there were 6% of patients with excellent biopsy, because before this study, we tend to do a lymph node staging only in higher risk patients. And finally, because at that time there was a discussion whether excellent biopsy is also a good choice for high-risk patients, where the tumor is large, it can fill in the whole uterine cavity. And this was the Swedish trial, prospective longitudinal observational study, which showed very high sensitivity for excellent biopsy, even for high-risk endometrial patients. So that's why in our recommendation, SLN is considered a standard option of lymph node staging from low risk, intermediate risk to high risk endometrial cancer patients. There are other aspects which required our attention. One of them was there was for quite a long time discussion about the best tracer injection site, because endometrial cancer is different from cervical cancer. In cervical cancer, almost all SLNs are located in the pelvis, while endometrial cancer, as we know, the distribution of positive lymph nodes can be also in the para-aortic region. And by injecting the tracer into the cervix, we very rarely find sentinel lymph nodes in the para-aortic area. And one of the protagonists of hysteroscopic injection of the tracer were Italians. And it was by surprise that the conclusion from Italian prospective randomized trial, so they randomized patients into those in whom tracer was injected to the cervix and hysteroscopically to the uterine body or to the uterine fundus, was that indeed in hysteroscopic arm, there were higher proportion of patients with para-aortic localization of sentinel lymph node, but in general, detection rate of SLN was much higher in cervical injection. So their conclusion was that cervical injection allows better identification of sentinel lymph nodes than hysteroscopic injection. And then I must say that internationally, cervical injection is now considered a standard way how to detect SLNs. Morbidity, lowering morbidity was the original intention. So instead of doing, removing all lymph nodes from axilla or groin or the pelvis, to select just 2 or 3 of them, remove them, and leave other lymphatic drainage intact. 2 aspects I'd like to emphasize here. This is one of the retrospective studies showing indeed lower rate of lower leg lymphedema. But one important aspect is that it's not zero. By doing SLN instead of pelvic lymphadenectomy, we do not eradicate lower leg lymphedema. We just lowered the rate or lowered the frequency. The severe lymphedema is very rare, as we know, but if we consider subjectively reported lymphedema, there are still some patients. So it's not from 50% to 0, it's from 40% to 20%. Another aspect is that it's very difficult to evaluate a lower leg lymphedema. In the cervical cancer study, we measured lymphedema objectively, and at the same time, patients reported subjectively. And there was surprisingly poor correlation between objectively and subjectively evaluated lymphedema. So it's another aspect which needs to be taken into consideration. But what is even more important benefit from SLN concept, besides lower morbidity, is better accuracy of lymph node staging. Because what we do, instead of sending to pathologists 20 or 30 lymph nodes per patient, we identify 2 or 3 of them. We send it to pathology saying that, guys, those are the most important lymph nodes in this patient. And pathologists can perceive these lymph nodes differently from a standard pathological assessment. We call it pathological ultrastaging. I don't have time to go into details, but here I'm showing you data from the cervical cancer, from the CENTIC study, because in this study we had a central quality control. So we send the samples for central reading, and we were able to identify the level of ultrastaging at which positive lymph node was detected. And we showed that with more levels, we always add some additional patients with positive lymph nodes. And we also show that by ultrastaging, we add about 50% of patients with positive lymph nodes. So if you think about the whole concept that the aim of SLN biopsy is to do staging, and by SLN ultrastaging, we almost double the number of patients identified with positive lymph nodes. So in other words, the main benefit from SLN concept is really to increase detection rate of the patients with positive lymph nodes. It leads us to the impact of so-called low volume disease. So low volume disease is just empiric classification. Those are metastases smaller than 2 millimeters. There has been a long discussion about the prognostic impact. So are those small metastases different or the same prognostically as metastases bigger than 2 millimeters? First of all, the number of patients who are diagnosed with so-called micromets or isolated tumor cells is not negligible. In some studies, is almost the same as the proportion of patients with macrometastasis, depending on the cohort. And this is one of the huge retrospective analysis from National Cancer Database, almost 90,000 patients. And you see that even micrometastasis, either found in pelvic or aortic sentinel lymph nodes or lymph nodes, have a prognostic significance. The question mark still is on the prognostic significance of ITCs. ITCs is now can be the whole lecture, but make it short. ITCs is the entity which is very difficult to answer the question whether ITCs have or do not have prognostic significance, because in principle they are so small that we will never be able to detect all of them, even by using a maximal intensity of ultrastaging. So in other words, we will never be able to completely evaluate its prognostic significance. One of the last topics is that has been a discussion whether SLN should not be also performed in patients with precancer endometrial lesions, so atypical hyperplasia or intraepithelial neoplasia. Several studies analyzed retrospectively their data. This is one of very recent meta-analysis from last year, showing that the risk of positive lymph nodes in this cohort is very, very tiny, small, is about 1%. So in general, we do not consider this cohort as a cohort which needs SLN biopsy or any lymph node staging. And finally, just to show you what are the ongoing trials or large international studies in this field. This is a German HEO trial randomizing the patients to systematic lymphadenectomy versus no lymphadenectomy. So a similar question which has been asked already by these two previous, but for current standards, older study. We currently use different prognostic parameters, molecular classification, so it's fully rationale to conduct such a study. This is a Korean study randomizing into SLN versus lymphadenectomy, and similar Chinese study, the question whether SLN lymphadenectomy, because if you consider that the trials I showed you, all of them were designed to answer the sensitivity. So they just compared the SLN status versus lymphadenectomy status. But we do not have in endometrial cancer any prospective evidence that there is no that SLN is safe in terms of oncological outcomes. So these trials should answer that. But finally, this is the trial which I consider very modern, and unfortunately for us surgeons, can change the future standards for the management of endometrial cancer, because it randomizes patients into SLN biopsy, which is indeed current standard, and no lymphadenectomy. So it might be that this trial will show no survival benefit, because what we need to see is that based on SLN status, we can tailor adjuvant treatment, and by tailoring adjuvant treatment, the outcome of these patients, there will be some survival benefit. If not, we can lose SLN, any lymph node staging in endometrial cancer. And indeed, there are already the trials, this is one of them, retrospective trials, if they combine traditional risk factors with molecular classification, lymph node status is no more significant prognostic factor. And with this question mark on the future of lymph node staging in endometrial cancer as such, I'd like to finish my talk. Thank you.
Thank you very much, David. This was a fantastic talk, systematic overview from the history till the present and the future. Thanks a lot. Remy, Xavier, we have some questions.
Yes. Who starts?
Well, we can start with, I'm just also looking at the chat. Is omentectomy indicated in P53 mutant high-grade endometrioid carcinoma for staging purposes? I think we did not yet touch that topic.
Actually, we have tried to touch the topic when we discussed it during for the staging, peritoneal staging in some specific histotypes. We haven't discussed about the molecular status and the staging, because we don't have information enough to tailor surgery based on molecular status right now. There are some studies ongoing, so actually we are doing staging now within a clinical trial for all patients, and then the objective is to assess the rate of peritoneal metastasis, even microscopic, regardless histotype, based only on molecular status. But we don't have data yet. I can tell you that the preliminary analysis of the Eugenie trial has shown a higher rate of microscopic metastasis in the omentum for P53 mutated patients, but this is not enough to give suggestions for the future now.
And this was also seen in a nice study of Sloan Memorial Kettering in the P53 abnormal group, nice series, retrospective, also higher rate in the P53 abnormal. But we still need more data on this in order to change surgical management. And particularly in this study, there were only very little cases of high-grade endometrioid. They have around 25% of P53 abnormalities, and we really can't say anything about histological subtypes in combination with molecular by now.
Yeah, there is one question which is also close to pathology, Anna, that's for you. What were the difficulties encountered on histological type determination on endometrial biopsies? Was any type specifically better or worse in correlation?
As far as I know, but it's also for you. As far as I know, there wasn't. But I can tell you what is my opinion in this regard, and it is more related to the procedure itself. I mean, most of the data that we have from the literature refer to biopsies taken with DNC. not with hysteroscopic biopsy. And I think that the differences, especially in terms of grading and maybe also in terms of histology, is related to the site where you perform the biopsy. So if I do it based on visual guidance, I can take the best biopsy I can have to represent the tumor. Whereas if I do it blinded, as during DNC, maybe I can miss this. I don't know if you agree, Xavier.
I always fully agree with you.
No, you can say the truth.
So I agree what you said. And also, of course, is the abundance of material. There is a subset of endometrial cancers that are heterogeneous. If the material is taken blindly, as you said, or the biopsy is very small, the chances that the picture that you are picking in the biopsy is not representative of the whole tumor, that also, it's always happening. But so thanks. I fully agree with you, Anna.
Thank you.
There are important sentinel lymph node questions for David in the chat. So one is, what is the role of sentinel lymph node in countries where ICG is not available and only methylene blue available? And should we replace sentinel with systematic lymphadenectomy if we don't have ICG?
Well, that's not a difficult question. We've been using other tracers for decades, and it worked quite well. So ICG has a higher detection rate. That's especially in endometrial cancer. It's interesting that the detection rate is higher, especially in endometrial cancer studies. It's not that much seen in cervical cancer, probably because of obesity of these patients. But by blue dye or radioactive tracer or a combination, you still can achieve a very good detection rate. And once you detect SLN, it doesn't matter whether this was detected by blue dye or by ICG. The sensitivity is the same. So I definitely advise to do at least any method you have available. Absence of ICG should not be an excuse for doing full lymphadenectomy, because the morbidity here, especially if we speak about pelvic and para-aortic lymphadenectomy, is detrimental. So definitely do SLN. And also, what I try to emphasize is that it's not only that you remove the lower number and that you preserve some proportion of patients with lymphedema, but it's also that you significantly improve your accuracy of lymph node staging. What's the purpose of this procedure?
Excellent, and very important further questions on para-aortic lymphadenectomy. So one question is, if the sentinel lymph node is positive in the pelvic, what to do? Should we do para-aortic lymphadenectomy or not? PET-CT, what is the procedure? And in general, what is the role of para-aortic lymphadenectomy? Has it still a place in endometrial cancer?
Well, so first, what to do if SLN is positive? So we can have two situations. One is that we take SLNs, send them for frozen section, and then to somehow adopt our next step during the same surgery. We don't do that because in endometrial cancer, even positive SLN is not an indication for full lymphadenectomy if lymph nodes are not suspicious by imaging. We really have currently a good data that lymphadenectomy in endometrial cancer is not curative. So there is no reason why to do it. Just positive lymph node is another prognostic factor. It's still well established as an important prognostic factor. So we use it for tailoring adjuvant treatment. but it's not an indication for systemic treatment. And it also answers the second question, whether there is a place currently for para-aortic lymphadenectomy. Well, no. There is no indication currently. I know that it's difficult, and I must say that it is for even training in gynae surgery, because lymph nodes in endometrial cancer was our primary source of patients for these procedures, but it's no more. There is no indication for systemic treatment, and we do it only if we see enlarged or suspicious lymph nodes on imaging.
So very clear. I think we could further discuss a lot of questions on this topic, but we need to move on with advanced and recurrent. And if we have time at the end, we can still address some of these questions. Remy, who is next?
Our next speaker, I'm very happy to introduce again Christina Fotopoulou from the Imperial College London, who will discuss with us the topic on surgical management of advanced disease, stage 3 and 4, and relapse endometrial cancer. Christina, please.
Thank you so much, Remy. Thank you also so much to Nicole and Javier for inviting me today. It was a great a year where we did the guidelines, so it's excellent that we can present it to the community. So we will go away from the landscape of early disease sentinels, where we heard some amazing and very evidence-based studies from David and Anna. The surgical management of advanced and relapsed ovarian cancer is more has much less prospective randomized evidence-based data, so it was more a consensus, and we have used the fact that we have changed in the new FIGO classification the definition of stage 4, 3, and 4 disease. As you all know, here are my conflicts of interest. As you all know, we have changed peritoneal carcinosis in the new FIGO staging when present till the pelvic rim, so pelvic carcinosis, that it's not stage 4 anymore, but it is stage 3, so that we give the patients a higher window of opportunity. So I will present you now in the next few minutes the recommendations that we have defined for specific cases and subcases and special considerations for our patients. So advanced disease, surgery for clinically overt stage 3 and 4 disease, so more advanced patients, including those with carcinosarcoma histologies. So what we have very clearly said is that surgical site reduction is, as also in ovarian cancer, the way to go, assuming that the macroscopic complete resection can be achieved and assuming that this can also be achieved with an acceptable morbidity and quality of life. We sometimes make the mistake and mix up ovarian cancers with endometrial cancers and assume it's the same surgery, the same dissemination patterns. This is not necessarily the case. All of us who operate know that sometimes advanced endometrial cancer can infiltrate the entire vagina, the parametria, in ways that ovarian cancer doesn't really do it. So we would need to perform complete vaginectomies and really impair impair the quality of life and the functionality of the patient. So we need to be very careful when indicating primary surgery in advanced disease, whether this is the way to go, especially since we have much more now targeted agents depending on the molecular profile. Something that David already has addressed, we know that there is no therapeutic benefit of removal of normal lymph nodes. So systematic lymphadenectomy of microscopic disease is not recommended equally to the ovarian cancer patients, but debulking of bulky ovarian lymph node disease should be, of course, performed if safe enough. So this is the algorithm that we have designed for you. Surgery for clinically overt 3 and 4 disease. We have to have, of course, always a full preoperative staging, CT, MRI, discussion in an MDT, even in non-centralized cancer care system, even in in countries where there is no accreditation necessarily of gyne-onc. We now have ESCO accreditation. We now have the concept of MDTs, of tumor boards, that needs, especially in those patients, to be key and is crucial for the correct management. So we have as a first question to see whether we can achieve complete macroscopic resection feasible with acceptable morbidity and quality of life. If yes, then we have to offer the patient the primary surgery in a specialist center. So we have to see whether the patient is in a specialist center. If not, either due to local extent, again, as I discussed with the vaginal involvement, or unresectable disseminated disease, then the patients need to divert to non-surgical options and then reevaluate surgery later. Very important, as discussed before, a primary exenteration with complete vaginectomy, complete removal of the bladder, rectum. In treatment-naive patients with endometrial cancer, it's not something that we would recommend, even if it's technically feasible. So what happens if there is an unresectable disease and surgery primarily is not an option? MDT should then consider, depending on the molecular subtype, definitive radiotherapy, a systemic treatment, the combination of both, and image-guided brachytherapy is recommended to boost, of course, any uterine, parametrial, or vaginal disease. And then we need to see whether, after good response to primary systemic treatment, a delayed surgery equal to the concept of ovarian cancer would be feasible, depending, of course, again, on the tumor dissemination patterns, the morbidity, and the patient's wishes. What happens if starting with neoadjuvant chemotherapy surgery is still not an option? Then we have to see whether further, so perhaps, for example, the patient has had 3 cycles of carbotaxol, the whole vagina is still involved, or still large parts of the vagina are involved, the parametra are involved, miliary carcinosis is there. What do we do? We need to see whether there was some degree of response in order to continue with 2-3 more cycles, again, equal to the example of ovarian cancer, or if it's a local problem, to go and proceed to definitive radiotherapy in order to localize, to keep the local disease under control. If surgery becomes a viable option, then non-surgical treatment should be stopped. We should operate the patient, perform site reduction, and then we have to see afterwards, depending on the residual disease, whether further systemic treatment or consolidation radiotherapy is the way to go. But there should be some type of consolidation afterwards. So this is the scheme for you. Unresectable stage 3 or 4 disease. Always, as a first step, consider molecular subtype. I'm sure that many of you, like me, in our MDT, we have seen extensive peritoneal disease, extensive local disease in DMMR, in deficient in DMMR patients who go to immunotherapy, and then everything was just melted down. So we should take advantage of those new approaches. I mean, I'm a surgeon, and as David said, we now have so many studies that show perhaps that, surgery is not the way or the value as we thought it would be, but at the end, it's important to do what is the best for our patients. So what happens with incomplete primary surgery in advanced disease? All of us who see patients with endometrial cancer are not necessarily operated in centers or had an incidental finding of endometrial cancer. What do we do with those patients? So what happens with those patients? The first question is where the surgery happened. Was the surgery happened in a cancer center? Was it in a specialist team? Yes or no? If no, the first step would be that this patient is referred to a specialist center, and not just to be just as inoperable and just be rendered as palliative and be sent to a to palliative care or to just some palliative chemotherapy. So depending on where the disease is, let's have a look systematically what we would do. What happens with residual lymph node disease in the pelvic or paraortic area? A residual lymph node disease should be reassessed in a specialist center, whether resectable. If it is resectable, we should resect it. David already talked how difficult it is to teach now paraortic lymphadenectomy. I see that also in my practice. We don't teach anymore systematic lymphadenectomy in normal lymph nodes. We have to really teach it when there are bulky nodes, which is much more challenging for the teacher, but also for the students. So this is something that we all have to learn to go with. If the residual lymph node disease is not resectable, then we have to see primary systemic therapy, depending on the molecular profile, or even EBRT, in order to deliver it to the pelvic and parotic area. If there is pelvic residual disease in the vagina, pelvic side wall, bowel, if it is in the vagina and the whole vagina is involved, again, complete vaginectomy primarily would not be something that we would recommend. If it's on the bowel, on pelvic side wall, and it is something that can be operated, then we should go for it. Otherwise, again, we have to see other options. Again, radiotherapy in case of bowel disease. We need to be careful whether this patient will get a fistula, needs a stoma. So these are all things that will have to be discussed within the MDT, what would be the best approach. What happens with recurrent disease? The evidence in recurrent disease is even more scarce in terms of prospective randomized evidence for local regional recurrence in radiotherapy naive patients, which is the first question that we always need to ask. Has the patient been pretreated with radiotherapy or not? Then radiotherapy is in local regional recurrences the way to go. If we have a very easily accessible superficial vaginal tumor in radiotherapy naive patients, of course operate, and then we have to see whether consolidation brachy is necessary or intracavitary IGBT alone, in order to have the best outcome. And these situations are even curable despite the relapse. What happens in radiotherapy pre-treated patients where we don't have anymore necessarily this as a first option? Then we can. So those who have had only brachytherapy, then we have, of course, to consider EBRT with IGBT boost. If the patients have had a whole pelvic radiotherapy, then I mean, we had with Remy a lot of this discussion in the vaginal cancer guidelines. There are specialist centers that can re-irradiate, but it may be challenging. In those patients, we really need to see the molecular subtype. We need to see first if any systemic IO options are available, and this should be the first way to go. In DMMR patients, it's very clear that chemotherapy followed by immunotherapy is something that is very key in our guidelines. What happens with radical surgery? Radical surgery, if we can achieve clear margins, if we can achieve that with feasible morbidity, then yes. We had during the review of our guidelines a lot of feedback regarding the value of exenteration, where many of you have said that we really need to be very careful before proceeding to an exenteration in patients who have other non or less radical non-surgical options. But at the end, it might be that we need to do a salvage pelvic exenteration, especially for palliation or when all options are exhausted. What happens with delayed surgery in the recurrence? This is a very gray area, hardly any data. Yes, we can start with systemic neoadjuvant type chemotherapy even in second line, and then see whether delayed surgery would be an option. We have left it open, or even re-irradiation, so that at the end we can do the best for the patients depending on their particular profile. So this is the algorithm for you: local regional recurrent disease. First question, radiotherapy naive patients, yes or no? And then you can see here very nicely what would need to be done. Again, key, the molecular profile of the patients. And something that we have especially addressed for our guidelines for the first time, as also we have done for the recent ovarian cancer guidelines, is the concept of the oligometastatic recurrent disease. This is a new concept, especially in the era of new targeted agents, immune checkpoint inhibitors, and the entire IO, is the concept of oligometastatic disease. What does this mean? Oligo means little in Greek. And it means it's defined as 1 to 5 lesions in up to 3 regions as relapse. So not this diffuse carcinosis or extensive many multifocal disease. So what are the treatment options there, as this is a local, as we want to call it, relapse? options, treatment options are local. You can have it, we can include surgery, we can have a local radiation therapy, including stereotactic radiotherapy, even in possibly previously pretreated patients, and also local ablating techniques, cyber knife, etc. So the ways are open, and again here key referral to a specialist center. What happens after local treatment? Do we need to give systemic disease, a systemic approach? I mean, the concept of oligometastatic disease is new in patients who have not been IO pre-treated, especially in the MMR profile. Of course, we would proceed to systemic therapy. So the question is about what the symptoms are, whether there is residual disease after local treatment, what are the options in terms of systemic advances, and also weighing the toxicity for the patients. What happens in disseminated recurrent disease, peritoneal carcinosis, especially in serous endometrial cancers? Again, here, yes, surgery can be an option. We have even in Imperial presented the concept successfully of recurrent site reduction, secondary site reduction like in ovarian cancer. However, again, key here, acceptable morbidity and quality of life. These patients with relapsed endometrial cancers, they will not have the same prognosis as the ovarian ones. So even though, again, it's technically feasible, we should be very careful before going there. There is a new large study from Florian Heitz from the German AGO, the STREAM study, which is a study that will evaluate the site reductive surgery at relapse, or even primarily in peritoneal disseminated endometrial cancer. It has just started. It's first, like in the desktop series, a retrospective review of all debulking cases, primary and relapse. Then we want, as a next step, to consolidate and define a score, like the AGO score for ovary, and then with the prospect in the future to do even a prospective randomized trial of site reduction in peritoneal disease or not for endometrial cancers. Palliative concepts, palliative radiotherapy, again, depending on where the disease is, very important. Be careful, especially in peritoneal disease, fistulas, bowel fistulas, urological fistulas, cloaca. So again, it is not a ticket free out of jail here. If we don't operate, we need to be very careful. What is how have we defined this in our guidelines? Non-locoregional recurrent disease, including oligometastatic or disseminated disease. We have to see, does the patient belong to this or that category? Where here we have more options. Here we need to have in the front more the palliation, the quality of life, the symptoms, and the molecular profile of our patient. Thank you very much.
Thank you, Christina, for guiding us so excellent through this, quite complex topic. Still, there are so many options and situations, and highlighting the role of surgery. Please, if you have questions, also write them in the Q&A. There are still some questions on the central node. I don't know, Nicole, if you want to proceed.
This was a fantastic overview. Thanks a lot. And we're very lucky to have now both still with us, Christina and David, to target all the surgical questions. So, Christina, this was very detailed if we stay with advanced recurrent. So, this is about surgery.
Mm-hmm.
The primary advanced stages. So, what is your key message for surgical evaluation of primary advanced stages? When do you decide to do surgery in a patient? And when do you decide to give systemic therapy or...
Yeah.
What is the decision? What is the key?
Yeah. No, absolutely. So I think all of us, we are making the decisions on endometrial cancer patients based on our experience with ovarian cancer patients. Advanced disease. However, we keep forgetting that these are actually not the same patients, not the same tumor. Yeah, neither the tumor biology of the disease is the same, nor the profile of the patient is the same. As As the speakers in the David and Anna have already, and also you have said, we very often speak in endometrial cancer from obese patients, high BMI, elderly patients, frail patients, where it's very tricky to go and strip the diaphragm and do two anastomosis, especially in cases where there are other better non-surgical options. So I think what I would first see is not whether, so first of all, whether there are any absolutely no-goes like liver mets, lung mets, PEs, etc., where primary surgery would be absolutely no. If the disease appears operable in extensive disease, we're talking now about extensive disease, aren't we? Extensive stage 3 and 4 disease, yeah. Then where we say, okay, technically it is resectable, but would it make any meaning? The first thing that I would see is how is the molecular profile of the patient. If this is a DMMR patient, I wouldn't necessarily go and do 3 anastomoses before giving an IO. Yeah, as much as I like doing bowel anastomosis. If it is a proficient patient with bowel symptoms and clear cell histology, where I know that the response to chemotherapy is not necessarily great, and the patient is fit, is young, and I don't need to perform a complete cystectomy or vaginectomy, then I would operate. Yeah. As I have said in my talk, I would absolutely not perform a complete vaginectomy or a primary exenteration in endometrial cancer. I would not do that. Yeah.
So you stressed very nicely, this is not ovarian cancer. This is not the surgical result and the PFS thereafter. This is different.
Absolutely.
A lot of considerations you had. And
Nicole,
David, do you want to add anything
yeah.
on this consideration? Yeah.
Just one aspect to what Christina has just said. If you do an analysis of the mortality of patients with endometrial cancer according to age, the age is crucial factor, and the morbidity is increasing with the age. And we see these advanced disease usually in very old patients. So it's not like one cohort of endometrial cancer patients, but usually those who are the oldest and who are with all the comorbidities, and those are the patients who come with very advanced disease. And this is one of the reasons why actually in our clinical routine we do these cytoreductive surgeries for endometrial cancer so rarely.
Yeah, fully agree. I mean, we know this data also for the ovary. I mean, these are all the data from Felix Hilpert from the AGO, where the mortality in a patient after primary site reduction in a 75-year-old with more than 2 comorbidities, yeah, is something like 60% the 3 months mortality, something dramatic numbers. Yeah. So, and we also have seen it in the AGO fragile. So fully agree. I think the STREAM study that I have quoted before and is just now starting will delineate everything a bit more and shed a bit more light. But I think we all are in agreement that we shouldn't just heroically go and debulk patients just because technically we can do it. It's not necessarily always the right thing.
And it's an important mention what David said. I mean, in ovarian cancer, 2/3 of patients are diagnosed with advanced stage disease. In endometrial cancer, it's the minority that has advanced stage disease, and this is particularly old multimorbid, and we know the increasing.
Absolutely.
Yeah, and these are the sick patients. So we need to evaluate them properly. And as you said, Christina, also other things like tumor biology obviously already influence our decision making. How can this patient not only resectability, can she tolerate? How is the performance status? How will she will she recover from surgery? How is her response to systemic treatment, etc.? So very, very important. what you also mentioned in the relapsed situation, in the recurrent situation, this is about surgery. And you talked about radical surgery. So radiotherapy pre-treated patients, what is the role of radical surgery? What are the preconditions to decide on radical surgery? When do we really do radical surgery in a local regional recurrent radiotherapy pre-treated endometrial cancer, and what are the other options, and what is the decision tree? What are the key considerations besides certainly transferring this patient to a center and have an interdisciplinary tumor board discussion?
No, of course. So we are talking about radiotherapy pre-treated patients with local regional recurrence. Yeah. Okay. So per definition, those patients, I mean, in the majority of the cases, if they get operated, it will end up in an exenteration. Yeah, because it's very difficult to dissect, do ureteric implantations and what have you in a radiotherapy pre-treated patient with tumors. So usually it is an exenteration. So we need to be careful before going there, whether there are any other alternative options. So the first thing would be to see whether the patient has had IO, whether what is the molecular profile, and whether we can give, pembrolizumab, whether we can give something else. Yeah. And also the symptoms of the patient. I just had a patient with a clear cell endometrial cancer who had primary surgery a couple of years ago, stage 1, had radiotherapy, comes now with a big vaginal tumor fistula with stool and feces out of the vagina. Of course, she needs a diversion. Yeah, she needs some type of operation. And the question is whether we just do a diversion and give systemic treatment or whether we exenterate. So these are tricky discussions. And again, coming back to what David said, what is the age of the patient? What is the performance status? What are her wishes? Yeah. I had a patient actually a couple of weeks ago with that concept who said to me, "Oh, you want to take out my bladder?" I said, "I don't want to take out anything." Where half of the bladder was open in a fistulation of the small bowel. So patients need to, it's very, I mean, the patients are not like they used to be in the past. They have read, they come to us, they have already,
Remy,
read the guidelines.
On exenteration.
Maybe
Remy,
also just
radiotherapist.
to highlight two important aspects, I think. The first is that in these situations, careful assessment by imaging is also really crucial, because you don't want to, the majority of these patients have disseminated disease, right? And it's only a minority that really has true local regional recurrence in this specific situation. So the imaging and ruling out any disease outside of the pelvic area is really very important. Then the second point, and why it's so important to do this in a multidisciplinary setting in an experienced team, is that you also want to have a critical assessment of the radiotherapy that has been performed. Where is exactly the location of this recurrence? Is it in an area? What dose did it receive? Is the option of retreatment an option or not? And weighing that against, well, the risks and benefits of surgery. So it's a really can be a very good MDT discussion where you really need to have this joint expertise in assessing the local the situation at the site of the recurrence and what will be the eventual outcome of the treatments.
Excellent.
And again, depending on the biology, for example, coming back exactly to what Remy has said, if there is a peritoneal relapse, in a fit young patient, peritoneal relapse of endometrial cancer operable, I wouldn't, even if it's only peritoneal carcinosis in the pelvis, I wouldn't irradiate. Yeah, because then I have a high risk of fistulas. It's anyway peritoneal dissemination. I would operate. There I would operate. Yeah, so we need to see also how feasible any surgery is, and by doing something, what are the options that we then exclude in the future? For example, by irradiating, but then any surgery is associated with an exenteration. So if we can operate, especially in peritoneal disseminated disease at relapse with an anastomosis, without giving the patient a stoma, then I think we should do it.
So, but now we're with the local regional relapse, pre-irradiated, considering radical surgery, exenteration. What are the considerations, David? What are the prerequisites? When is this an option for the patient? How do we evaluate this patient?
Well, there are some retrospective data comparing patients after exent based on the type of tumor. And in general, there is no much difference in the outcome, in the oncological outcome between those with endometrial cancer and cervical cancer. If we speak about recurrence in the pre-radiated pelvis, if they analyzed the data from endometrial cancer patients, the prognosis was related to the tumor histology, which is what we would expect, that serous cancer did worse than endometrioid cancer or undifferentiated cancer. So this is one. We have, very limited or no data on the molecular classification, but we can expect that it's another interesting factor to this puzzle. But otherwise, we would consider, the same aspects for the exent patients. So the first and foremost, as Remy already said, our first attention is to exclude any distant disease, because to do exenteration in the presence of distant disease, and we include paraortic here, would be a big failure. It's such an extensive procedure should not be done there. And then the main criteria besides this is to achieve free surgical margins, because this is the most important prognostic factor in any exent patient. To do exenterative surgery with the stomas and with so much more morbidity, and to leave 1 millimeter tumor behind us is simply a failure, because a patient will recur very soon. So this is what we have to evaluate.
And this was really, I was waiting for this, because this is, so we really need to assume, we need to be quite sure that we can reach clear margins if we decide on this. And in our quality indicators, endometrial cancer surgery, we mentioned that this really needs to be accomplished. Otherwise, if then you misinterpreted, or you did not, your estimation was wrong, and this should not happen in endometrial cancer patients in this situation. So really evaluate your patient well before deciding on this. Christina.
Very, very important, because also David mentioned the cervical cancer patients. So of course, exenteration has always to have clear margins. Whereas, for example, in cervical cancer, we would never exenterate or consider exenterating in the presence of peritoneal carcinosis. Nobody would even think of going there. In endometrial cancer, we need to be careful, because sometimes they might have been radiotherapy pre-treated in the pelvis. Yeah. And then they relapse with peritoneal carcinosis and pelvic disease. And there are people who would say, let's do a site reduction and exenteration. So extensive procedure. I would not recommend it. I would not do that. Again, clear margins and exenteration, very important. In the presence of peritoneal disease, not feasible to go and strip the bladder and strip the rectum and do an anastomosis in a pre-irradiated patient in the pelvis is extremely difficult and has high morbidity. So to combine the exenteration and peritoneal site reduction is something that also I would not recommend. And this is something special to the cervical cancer patients. Cervical cancer patients, nobody would ever think of doing it, but because endometrial cancer, depending on the biology of the disease, may recur peritoneally, and people might think it's like an ovary, let's site reduce. If they have been radiotherapy pre-treated, we simply cannot do that, not in a safe way.
So I think this was an absolutely fantastic discussion now. Thank you very much. Remy, do you want to add at the end something to this discussion, or?
Only maybe briefly mention as a follow-up on the question that was for David in between on the ICG. I think it's also good to just mention that there will be work done starting later this year on a resource stratified guideline also for endometrial cancer. So that is something to expect in the near future. I think it's important because some of the questions address this topic of low resource situations.
Yes, David pioneered this for cervical cancer and presented the data at ESCO Congress in Rome, and we will also move on in this direction with endometrial cancer.
And maybe Nicole, before giving the word to you to finalize, also just on my behalf and from Estro, just to thank Anna, David, and Christina for their excellent contributions to this webinar. Thank you.
I can only echo Remy's words. It was fantastic having Anna, Christina, David with us today. Thank you very much. Thanks to the audience for fantastic questions that prompted a great discussion. And we all hope to see you again at our next webinar, which will take place on 22nd of May on adjuvant treatment. So thanks to great faculty again, and have a nice evening. Bye-bye.
Thank you. Thank you. Bye.
Thank you. Bye.
Bye-bye. Danke, Christine.